Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. Thanks to your support, our channel has grown steadily. If you have any topics you'd like to see covered, please leave a comment and we'll actively consider your suggestions.
Today, we're going to build a complete masterclass on ECMO, literally from the ground up. We'll kick things off with the absolute fundamentals, the critical differences between VV and VA ECMO. From there, we'll explore the incredible paradigm shift of Awake ECMO. Then we'll get practical and walk through the anesthesiologist's perioperative playbook, learn how to manage some really high-stakes complications, including a deep dive on Harlequin syndrome, and finally, we'll look to the horizon at the evidence-based future of this amazing life-saving therapy.
All right, let's dive right in with the fundamentals. Because truly, every single decision we make with these patients, whether it's the initial cannulation or managing a sudden crisis, is built on a rock-solid understanding of these core principles.
So, at its very heart, what is ECMO? You can think of it as the most sophisticated heart-lung machine we have, but designed for the ICU. Now, the key concept I really want you to hold on to is that it's a bridge. ECMO doesn't actually cure the underlying disease. What it does is buy us precious time. It's a bridge to recovery, a bridge to making critical decisions, or a bridge to transplantation. And how we build that bridge depends entirely on which organ system has failed.
This brings us to the two main configurations, and you can think of them as two completely different highways for blood flow: veno-venous, or VV ECMO, and veno-arterial, or VA ECMO. VV ECMO is purely for respiratory support. It takes deoxygenated venous blood out, runs it through an artificial lung, and returns that fresh oxygenated blood right back to the venous side. It's basically doing the lung's job. In sharp contrast, VA ECMO supports both the heart and the lungs. By returning that oxygenated blood directly into the arterial system, it provides full circulatory support, effectively bypassing the patient's own heart and lungs.
And this table really breaks down those core differences beautifully. With VV ECMO, the patient's heart absolutely must be working. We're not helping the pump, we're just handling the gas exchange. The biggest technical headache we face here is recirculation. That's when the freshly oxygenated blood we just returned gets immediately sucked right back into the circuit. Now, VA ECMO is a different beast. It provides that full hemodynamic support, but this creates a huge new problem. By pumping backwards into the aorta, we dramatically crank up the afterload on the left ventricle. Managing that LV is one of the most critical tasks for us as anesthesiologists.
Okay, now let's explore something that is a true game changer in ECMO care. We're talking about moving away from just passively supporting a patient to actively engaging them in their own rehabilitation by keeping them awake.
And just look at this image. This is not the patient we traditionally picture on ECMO: deeply sedated, paralyzed, completely passive. This is someone who is conscious, breathing on their own, and actively participating in the recovery. The entire goal of Awake ECMO is to sidestep those devastating complications of prolonged sedation, things like ICU delirium and profound muscle weakness, and to get these patients up and moving as early as possible.
But, and this is a huge but, this advanced strategy is definitely not for everyone. You can't just wake a patient up and hope for the best. Initiating Awake ECMO demands an incredibly meticulous, multidisciplinary assessment. Patient selection is absolutely paramount to ensure both safety and success.
This table really lays out that rigorous selection process. Physiologically, the patient needs to be stabilizing. They need to be on the upswing. For VV ECMO, for example, we're looking for patients who haven't been on the ventilator for too long. For VA, the shock has to be resolving, and we look for a pulse pressure greater than 10 millimeters of mercury, which is a good sign that their native heart function is starting to return. But just as important, maybe even more so, are the psychological and social factors. The ideal candidate is someone who is cooperative, motivated, and has a strong support system. Severe delirium or agitation, those are absolute contraindications. And the cannulation strategy itself is totally different and strategically vital for Awake ECMO. For a sedated patient on VV ECMO, using the femoral veins is pretty common. But for an awake, mobile patient, a dual-lumen cannula placed in the right internal jugular vein is the way to go. This single-site access in the neck completely frees up the groins and maximizes their potential to get up and walk. It's the same idea for VA ECMO. Instead of the standard fem-fem approach that essentially pins the patient to the bed, we'll choose an upper body strategy, using the axillary or subclavian artery, specifically to allow them to ambulate. These aren't just minor technical details. These are profoundly enabling decisions.
So this brings us right to our wheelhouse, the anesthesiologist's direct, hands-on role. Our deep expertise in vascular access, complex hemodynamics, and coagulation management is absolutely central to the success of any ECMO run.
As anesthesiologists, our role extends so far beyond just placing the cannulas.
It involves constant, comprehensive monitoring across multiple interacting domains. We are, of course, watching the patient's hemodynamics and their native lung function like a hawk, but we are just as responsible for the circuit itself, monitoring flows, pressures, gases, looking for any sign of malfunction. And critically, especially in an awake, moving patient, we are absolutely vigilant about cannular position and security, because a dislodged cannula is nothing short of a catastrophic code-level event.
This table details some of the most critical parameters we're tracking. For instance, on VA ECMO, the return of a nice, sharp pulse on the arterial line is just a beautiful sight. It's often the very first sign of LV recovery. Monitoring the mixed venous saturation, or SVO2, tells us how well the patient's tissues are extracting oxygen, which is a key metric for deciding if they can tolerate more activity in awake ECMO. And a rising pressure gradient across that oxygenator, that's an early ominous warning sign of clot formation that could lead to catastrophic failure. You see, every single data point tells a piece of the story.
Now, one of our most challenging minute-to-minute tasks is managing anticoagulation, and this is a true balancing act, a constant tightrope walk. On one hand, the foreign surface of the extracorporeal circuit is intensely thrombogenic, and we have to prevent clots. On the other hand, these patients are critically ill and incredibly prone to bleeding. Unfractionated heparin remains the workhorse here, mostly because it's cheap, has a short half-life, and we can reverse it. But it definitely comes with its own set of challenges.
We use a whole panel of tests because heparin's effect can be notoriously unpredictable. The activated clotting time, or ACT, is our rapid go-to bedside tool. The APTT is a common lab target we use to guide our infusion. For a more precise, specific measure, we'll look at the anti-factor XA activity. And perhaps most importantly, we monitor antithrombin levels. Because here's the thing, heparin is completely useless without AT3. If those levels are low, the patient becomes heparin resistant. We have to replace it to achieve our therapeutic goals.
All right, inevitably, despite all of our best efforts, we are going to face complications. So let's focus on two of the most significant and potentially devastating ones. Hemolysis, the mechanical breakdown of red blood cells by the circuit, and the dreaded heparin-induced thrombocytopenia, or HIT.
A systematic, stepwise approach is crucial when you suspect hemolysis. First, you identify it through rising lab markers like plasma-free hemoglobin and clinical signs like that classic tea-colored urine. Then you investigate the cause. Are the pump flows too high? Is the drainage cannula chattering against the vessel wall telling you there's inadequate preload? Or is there a clot forming somewhere in the circuit? Our interventions follow that investigation. We might back off on the flows or optimize the patient's volume status. If those simple measures fail, we have to escalate to a full circuit exchange, a procedure that is incredibly high risk, especially in an awake patient who is 100% dependent on that circuit for their survival.
HIT is an anesthesiologist's absolute nightmare. It's this paradoxical immune-mediated reaction where heparin, the very anticoagulant we're using, causes widespread life-threatening thrombosis. When we see a patient's platelet count suddenly plummet while they're on heparin, we have to have a very high index of suspicion. Once HIT is suspected, our first and most critical action is to stop all sources of heparin, immediately. That means flushes, coated catheters, everything. And then we have to switch to a safe alternative anticoagulant.
And this table shows our primary alternatives. Argatroban, which is a direct thrombin inhibitor with hepatic metabolism, is often our first-line choice because of its short half-life. Bivaluridin is another excellent option, especially for patients with liver dysfunction since it's cleared by the kidneys. What is absolutely vital here is that selecting the right alternative requires a very careful assessment of the patient's end organ function. Making a mistake here could be fatal.
Okay, now for a deep dive into one of the most classic, fascinating, and dangerous complications of peripheral VA ECMO, Harlequin syndrome. This is a critical phenomenon that every single anesthesiologist involved in ECMO has to understand, be able to detect, and know how to manage. So, Harlequin syndrome, which is also called differential hypoxia, happens as the patient's native heart function starts to recover. The recovering left ventricle starts ejecting its own blood, which has just passed through their very sick lungs and is therefore poorly oxygenated, into the aortic root. At the exact same time, the ECMO circuit is pumping perfectly oxygenated blood retrograde, or backwards, up the aorta from the femoral artery. These two different blood streams meet, and they create what we call a mixing zone, or a watershed. The huge danger here is that the deoxygenated native blood perfuses the coronary arteries and the great vessels supplying the brain, while the well-oxygenated ECMO blood goes to the lower body. The patient is literally blue on top and pink on the bottom.
Early detection is absolutely everything, and that requires multi-site monitoring. This is why we always place an arterial line and a pulse oximeter on the right arm. That's our window to the blood that's going to the brain. A significant oxygen gradient between the right arm and a leg is a huge red flag for Harlequin. We confirm it with paired blood gases. And cerebral oximetry using near-infrared spectroscopy, or NIRS, can give us an even earlier warning of brain hypoxia.
So once this is diagnosed, it is a true medical emergency. We have to act, and we have to act quickly, to restore adequate oxygenation to the brain and heart. We have several strategies at our disposal, and they range from simple bedside adjustments to much more complex circuit reconfigurations.
Our first step is often to optimize the ventilator settings. If we can improve the native lung function even a little bit, that will increase the oxygen saturation of the blood being ejected by the left ventricle. We can also try increasing the ECMO flow, trying to physically push that watershed zone more proximally, up into the aortic arch. But honestly, these are often just temporary fixes. The definitive solution usually requires us to reconfigure the entire circuit to deliver oxygenated blood to the right side of the heart.
And the ultimate, most elegant solution is veno-arterial venous, or VAAV ECMO. In this hybrid setup, what we do is add a Y connector to our arterial return line and send some of that perfectly oxygenated blood back into the venous system. This essentially pre-oxygenates the blood that's flowing through the patient's own heart and lungs. So now, the blood that's being ejected by the left ventricle is well oxygenated, and that completely resolves the differential hypoxia.
Okay, let's wrap things up by looking toward the future, where new evidence and new technology are really reshaping ECMO practice as we know it. This field is evolving incredibly rapidly, and it's being driven by robust data, advanced analytics, and a much deeper consideration of the ethical complexities of this powerful therapy.
You know, one of the most significant recent shifts in practice, and it's backed by some really strong evidence, is the adoption of a much more restrictive transfusion strategy. The new magic number for many of our stable patients, a hemoglobin threshold of 7 grams per deciliter.
And the evidence for this is just so compelling. A recent network meta-analysis found that a restrictive threshold of 7 was associated with a significant reduction in red blood cell, FFP, and platelet transfusions. But what's truly remarkable, what really made people sit up and take notice, is that it also showed a dramatic improvement in 28 days survival, with an odds ratio of over 4. This tells us that avoiding unnecessary transfusions doesn't just save blood products, it actually saves lives. Now, of course, this has to be individualized. Patients with active bleeding or certain severe cardiac conditions may still require higher thresholds.
And looking even further ahead, artificial intelligence is absolutely poised to revolutionize our ability to predict outcomes. New models, like one called ECMO PAL, are being developed using deep learning on these massive data sets from the Extracorporeal Life Support Organization, or ELSO International Registry.
The key difference between these AI models and our older scoring systems, like the SAVE score, is just profound. The SAVE score uses a small number of static pre-ECMO variables to generate a single prediction at one point in time. In contrast, ECMO PAL can analyze thousands of dynamic data points, hemodynamics, lab values, ventilator settings, in real time throughout the patient's entire course. This allows for a much more nuanced, accurate, and continuously updated prognosis. The potential applications for this are just vast. AI is going to become a powerful co-pilot for us right at the bedside. It's going to help us provide more accurate prognoses to families, allowing for better informed goals of care discussions. It will function as an early warning system, flagging patients who are at high risk for bleeding or thrombosis. It could even recommend optimal ECMO settings based on a continuous analysis of patient data, truly personalizing this incredibly complex therapy. And this really brings us to a final, thought-provoking question. As these incredibly powerful AI tools become more commonplace, how will we balance algorithmic prediction with our own clinical judgment? How do we ensure that they are used equitably and transparently? These are the questions that are going to define the next era of critical care. Thank you so much for joining this masterclass.